I'd like to make a start, and we have a session on rheumatology, which is very interesting. And being a rheumatologist myself, I do have the pleasure of introducing three of my colleagues. I have a peripheral tangential interest in nuclear medicine, but not as much as Dr. Poon, who's a nuclear medicine specialist. Now, the talks range from looking at diagnostics to management. I'd like to introduce the first speaker, Dr. Claire Owen, who is a colleague of mine who would like to talk about this interesting field of vasculitis, polymyalgia, and PET. These two diagnoses are very difficult to make and quite often difficult to assess and manage. And I think Claire has important thing to say about this situation. Claire, please, kindly.
Good afternoon, everyone, and my thanks to the organisers for asking me to speak today, and in particular to present some of the work that we've been doing at the Austin Hospital in the field of polymyalgia rheumatica. So I have no disclosures. The talk will comprise two parts. I'll begin with looking at large vessel vasculitis with a focus upon giant cell arteritis and also Takayasu's arteritis, with the focus being on diagnosis and follow-up in both of those conditions, before I'll change tact to look at polymyalgia rheumatica, a condition that has long been misunderstood, but which PET-CT is shedding new light on. So just to refresh, the systemic vasculitides are of course characterised by vessel wall inflammation and consequent reactive destruction of regional tissues. Patients may present with organ-specific or constitutional symptoms. The etiology may be infectious or non-infectious. In rheumatology, we tend to divide vasculitis by the size of the vessel affected into small, medium and large vessel vasculitis. It's particularly in large vessel vasculitis that diagnosis is often problematic. There are no diagnostic laboratory tests, and a biopsy may also not be feasible. Of course, there's avid accumulation of glucose and structurally related substances like FDG within the vessel wall in active vasculitis, and hence the role that PET may play in this condition. So when we talk about large vessel vasculitis and the application of PET, whilst there is some sporadic reports in the literature of use in both small and medium vessel vasculitis, the predominant application is in large vessel vasculitis and the two conditions that I've mentioned. So giant cell arteritis is a large vessel vasculitis that affects the aorta and its branches. This is the most common vasculitis in men and women over the age of 50. We see a female predilection, and patients are typically of Northern European descent, where there is a HLA association. Patients that present with cranial symptoms are typically more easily diagnosed, so they'll have headache, scalp tenderness, jaw claudication, or the most feared complication from this condition being sudden monocular visual loss, and that's secondary to acute ischemic optic neuropathy. 10% of patients, though, only present with constitutional symptoms and elevated inflammatory markers, and a further 15% will present as a pyrexia of unknown origin. In terms of the presence of extracranial disease, around about 45% of patients have involvement of their thoracic aorta and its main branches at diagnosis. These patients are typically younger, more commonly female, and their rate of temporal artery biopsy positivity is far less. The issue for this subset of patients is that they have the potential to develop vascular complications long term, such as aortic aneurysm formation and dissection and vascular stenosis. And it's these complications that are associated with an increased mortality in giant cell arteritis. So what does a PET scan look like in giant cell arteritis? Well, I'm sure you're all aware. We see a smooth linear or long segmental pattern of 18-FDG uptake, as you can see in the right-hand side there. How does PET perform as a diagnostic test for giant cell arteritis? Well, a recent meta-analysis would suggest that it has quite reasonable sensitivity and specificity. In addition, it is better than magnetic resonance angiography for documenting the sheer extent of involvement of extracranial disease. There is also proven to be a statistically significant correlation between vascular FDG uptake and the late volume of the thoracic aorta. And this is in fact a surrogate marker of the likelihood of developing thoracic aortic aneurysm. Finally, there's the additional benefit of being able to exclude relevant differential diagnoses in patients who have presented with atypical findings such as constitutional symptoms or a pyrexia of unknown origin. What about the limitations though? Well, generally speaking, the close vicinity of the PET-avid brain to the temporal arteries means that cranial disease cannot be diagnosed. I did note, though, that there is a poster downstairs looking at that particular issue, though. What we generally advise, though, is that the gold standard diagnostic test for giant cell arteritis remains temporal artery biopsy. That being said, the current large vessel vasculitis recommendations from the European League Against Rheumatism are that in a patient with a high clinical suspicion of large vessel vasculitis and a positive imaging test such as PET, that there is no need to go on and have further testing such as a temporal artery biopsy. Atherosclerosis is another potential confounder in this population given the age of the individuals involved. With the advent of hybrid technologies such as PET-CT, though, this should be a lesser issue. What about treatment? Well, unfortunately, initiation of glucocorticoid therapy obviously has a significant impact upon the sensitivity of this test. In particular, one study has demonstrated that the sensitivity fell from in the 90s to around 50% following only 3 days or so of glucocorticoid treatment. Finally, I think a major issue in this area is the lack of standardised reporting in giant cell arteritis. At this point in time in the literature, it ranges from qualitative assessments to semi-quantitative measures such as the Miller score and finally the use of SUV max. But clearly there's a need for more research as to how we should all be approaching this in a standardised manner. What about the utilisation of PET in the follow-up of patients who have known giant cell arteritis? Well, this has really been the landmark article in the literature to date, published by Daniel Blockmans in 2006. This was a prospective study of 35 patients that had biopsy-proven giant cell arteritis, undergoing PET at diagnosis 3 and 6 months. Not surprisingly, the vast majority had uptake at diagnosis. This decreased from diagnosis to 3 months, but there was then no further reduction in their FDG uptake from 3 to 6 months. So in other words, there was persistent vascular FDG uptake and the significance was somewhat unclear. Importantly, in patients who relapsed, there was absolutely no significant difference in the degree of vascular FDG uptake at diagnosis, 3 or 6 months, compared with those in a sustained clinical remission. So the conclusion up until now has been that PET is quite useful for diagnosing patients for extracranial disease. It is helpful for patients who are presenting with an atypical presentation, and it may also predict those individuals at risk of vascular complications. However, its role in monitoring disease activity has been quite questionable. This may change, though, following this recent publication. This is a prospective cohort study of 56 patients with large vessel vasculitis, 30 of whom had giant cell arteritis, and they were compared with 59 disease comparators, the majority of whom had just hyperlipidemia. These patients underwent PET-CT at diagnosis and 6-monthly intervals for a variable duration of follow-up. Now, it's worth noting that their protocol involved image acquisition at 120 minutes of uptake, which is somewhat different to most of the other articles in this area of the literature. In this particular instance, scoring was qualitative, but they also generated what they coined a PET-VAS score. This involved scoring 4 regions of the aorta, as well as a number of its tributaries. And then they scored this using the Miller score relative to FDG uptake within the liver. In many ways, they managed to replicate those findings that had previously been published by Daniel Blockmans, because the vast majority of patients who were deemed to be in clinical remission still had a PET scan that looked like it was active. However, the interesting finding from this particular study was that when they utilised a PET-VAS score of 20 as a cutoff, they were able to predict future clinical relapse. And so for the very first time in the literature, what we're seeing is that there may be the opportunity for PET to provide a qualitative score of burden of vasculitis, and that this may well be related to risk of future clinical relapse. Obviously, further studies are needed though, and there's a number of limitations from this study. It was a single centre. As I mentioned, it was only qualitative scoring, and it worries me about the image acquisition being undertaken at 120 minutes. The authors state that this was the recommended procedure for atherosclerosis imaging, but I think it's probably likely to have potentially increased the false positive rate. In particular, 17% of patients in the control group had a positive PET scan. So briefly to Takayasu's arteritis. Again, this is a large vessel vasculitis with a predilection for the aorta and its branches. It's quite different in that it predominantly affects Asian women who are young. The clinical presentation is quite difficult, constitutional symptoms and elevated inflammatory markers, and it's not until the end of their disease course that they begin to develop vascular-related complications due to stenosis and occlusion. Again, this PET performs quite well in terms of sensitivity and specificity for a diagnosis of Takayasu's arteritis. It is quite different though from giant cell arteritis in that there appears to be a better correlation between the presence of vascular FDG uptake and disease activity in this particular instance. It is not unusual though in patients with Takayasu's arteritis for them to be deemed to be in a clinical remission and yet still have quite profound FDG uptake on their imaging. So theoretically, PET could be quite useful for both diagnosis and follow-up of these patients. But the predominant limitation is the age of the patients and the radiation exposure associated with serial scanning. And hence, the current EULAR recommendations reflect this fact, suggesting that MR is the preferred imaging modality for this particular subset of patients. And that's not only due to the radiation, but also because MR permits evaluation of both the vessel wall and its lumen as well. On to polymyalgia rheumatica. So PMR is a chronic inflammatory disorder of unknown cause and the most common inflammatory rheumatic disease of the elderly, second in lifetime risk to rheumatoid arthritis. The pathology within the joint is really quite mild when it comes to synovitis as compared with other arthritis comparators like rheumatoid. Increasingly, we are appreciating from imaging studies that the predominant pathology in this condition is not intra-articular, but rather peri-articular, with involvement of structures around the joint, such as the joint capsule, tendon and bursa. Patients with PMR present with a very sudden onset of shoulder and pelvic girdle pain with associated extended early morning stiffness. Peripheral manifestations are seen in up to 1/2 of patients, and this can include synovitis, which resembles that of rheumatoid arthritis, or alternatively tenosynovitis. In its worst form, it looks like that on the right-hand side, which is called RS3PE syndrome, which is remitting seronegative symmetrical synovitis with pitting edema. So in PMR, there is a lack of a gold standard diagnostic test. Hence, we base our diagnosis on a clinical construct and elevated inflammatory markers. As a consequence, there has long been controversy as to whether PMR is a distinct disease entity in its own right or an umbrella term that can be applied to a number of different rheumatologic diagnoses. This is because as rheumatologists, we commonly see patients present with a polymyalgic presentation, and later in their disease course, they evolve to an alternate diagnosis, most commonly late onset rheumatoid arthritis. Concomitant giant cell arteritis also adds to the clinical conundrum, with the presence of this condition seen in 16 to 21% of patients with polymyalgia rheumatica. So if we're to characterise polymyalgia rheumatica's relationship with both rheumatoid arthritis and giant cell arteritis, this is probably a relatively good representation. It is often difficult to know where one ends and the next one begins. Not surprisingly, therefore, the application of PET in PMR initially focused on the incidence of subclinical large vessel vasculitis. And again, Daniel Blockmans was the first person to conduct a study in this area, finding that around a third of patients had some degree of vascular uptake. The ability of PET to detect articular inflammation, though, has really been the focus of subsequent work, with abnormalities seen at the shoulders and hip in the vast majority of patients, as well as documentation of a novel finding involving the interspinous regions. This has since been localised to the interspinous bursae on MRI. So this is what initial PET studies looked like in PMR, pretty grainy, and with some abnormalities in the shoulders, hips and interspinous regions. Of course, the evolution of hybrid technology and pairing of PET with CT has allowed us to further study the very distinct anatomic distribution of polymyalgia rheumatica, and we now know that there is a very characteristic pattern of FDG uptake, which is appreciated around the shoulder, around the hip in the trochanteric regions, in the interspinous bursae, and adjacent to the ischial tuberosities, which are the structures within the pelvis that most of you are sitting on currently. So this is the appearance of some of our PMR patients at the Austin, and you can see that the distribution of FDG uptake around the shoulders is not just located in the glenohumeral region, but around the joint itself. Probably even better appreciated in this image of the hip, so not just the hip joint, but around and including the trochanteric region. This is what interspinous uptake looks like on a PET CT. You can see this very hot uptake here. And indeed, this is the characteristic intense FDG uptake that is seen adjacent to the ischial tuberosities. And this site actually is essentially the hottest within the entire body of patients with PMR. So the distribution and intensity of FDG also allows us to potentially discriminate between PMR and alternate diagnoses. So this particular work from a Japanese group compared PMR patients with others who had spondyloarthritis or rheumatoid arthritis. What they found was that the FDG uptake was significantly higher in PMR patients compared with both rheumatoid arthritis and spondyloarthritis. The distribution was also helpful in distinguishing between PMR and rheumatoid arthritis, in that involvement at the ischial tuberosities and greater trochanters and interspinous involvement was seen in PMR patients. The same could not be said, though, comparing PMR patients with spondyloarthritis. So how does PET perform as a diagnostic test in PMR? Well, this is a very recent study looking at 99 consecutive patients who had a possible diagnosis of PMR at enrolment. 67 went on to have a confirmed diagnosis at 6 months, compared with 32 who were identified as an alternate diagnosis. That was predominantly rotator cuff disease or osteoarthritis. It's worth noting that these patients underwent only PET scanning, not PET CT, and the authors in this instance generated a total skeletal score, so you're beginning to see a bit of a trend here. But what they found was that none of the individual skeletal regions performed well as a diagnostic tool in terms of their individual sensitivity and specificity. However, when they utilised their total skeletal score and used a cutoff of 16, what they found was a relatively high sensitivity and specificity for a diagnosis of PMR. In fact, the PET performed better than the current 2012 EULAR ACR classification criteria for PMR. So quite rightly, the authors concluded that PET may well be a useful diagnostic tool in patients with suspected polymyalgia rheumatica, particularly those who have atypical presentations. In the last minute or so, I'm just going to focus on how PET-CT has really revolutionised our understanding of PMR. On the left-hand side, you're seeing the classic textbook depiction of this disease involving the shoulders and the hips. On the right-hand side is one of my patient's pain mannequins, and I'll draw your attention to the fact that there appears to be clear involvement of the hands, the buttocks, and also at the backs of the knees. And this brings me to our Melbourne Predictors of Relapse in PMR study, which we've been conducting at the Austin Hospital since 2014. This has been a prospective, single-centre cohort study where we've consecutively recruited untreated patients with polymyalgia rheumatica. All of these individuals have had a baseline whole-body PET-CT where we've performed the protocol from skull vertex to toes, including for the first time dedicated hand views. As I mentioned, many of our patients have complained of peripheral joint involvement in this condition from the beginning, and this is some of the results from our baseline PET-CT data. You can see that more than 50% of patients have complained of symptoms at these sites. And this correlates really nicely with some of the PET findings that we're seeing in this cohort. In fact, we see abnormalities of FDG uptake at the knee in 3/4 of patients and at the wrist or hand in at least 2/3. The patterns that are consistently seen at these sites are also incredibly distinctive. Rheumatologist Marco Cimino has previously reported this capsular pattern of FDG uptake in polymyalgia rheumatica, but we've been really struck by this PET avidity in the posteromedial structures. You can see it in both of these examples here. In addition, in the hands, we consistently see this pattern of uptake, which is a volar distribution of abnormal FDG uptake. But as is often the case in research, novel findings typically lead to more questions as to what you're dealing with. And in this case, the predominant question has always been, what are the precise anatomic structures that are involved when it comes to abnormal FDG uptake at these sites? In order to achieve this, what we've done is perform MRI in representative patients with abnormalities in their posteromedial knees, and then perform PET MRI fusion using technology. So the end result is that we've confirmed that the abnormality in the posteromedial knee structures in polymyalgia rheumatica actually represents a peritendinitis of the distal semimembranosus tendon. And this got us thinking about that characteristic intense uptake at the ischial tuberosities in the pelvis, which happen to be the origins of the hamstring tendons. And indeed, when you perform an MRI, in these patients with abnormal uptake at this site, what you see is that they have, again, a peritendinitis of their proximal hamstring tendons as the anatomic correlate of their abnormal uptake. And so for the first time in rheumatology, we understand why patients often complain of posterior thigh pain in polymyalgia rheumatica. It's due, in fact, to involvement of their hamstring tendons. Unfortunately, the same technique couldn't be replicated for the findings that I've mentioned at the hand. However, by performing MRI in some of these patients, we have managed to confirm that the anatomic correlate is indeed flexor tenosynovitis and, to a lesser degree, intercarpal synovitis. And interestingly, these are the hallmark imaging findings of the PMR-related condition RS3-PE syndrome, which I mentioned earlier in the presentation. So to conclude, it's clear that PET is playing an increasing role in assessing extracranial disease at diagnosis in giant cell arteritis, and also characterising the subset of patients who are at risk of future vascular complications. Whilst previously thought to possess limited value in assessing large vessel vasculitis disease activity, a recent study has in fact found the qualitative burden of arterial FTG uptake to be a predictor of clinical relapse, but certainly more work is required. In polymyalgia rheumatica, PET-CT is really shedding new light on the distinctive pathology that this condition involves, its extent and the precise structures affected. I'm happy to take any questions and just like to acknowledge my team at the Austin who are involved with this work.
Thanks, Claire. Wonderful talk. Lovely pictures. I just have two quick questions, but before I do that, I'd just like to invite the floor to speak in terms of questions. Please.
I'm Min Kyung from South Korea. Thank you for the lecture. In PET MRI, is it tandem type PET MRI or by Philips or synchronized PET MRI by Siemens? A simple question.
Yeah, so in our particular instance, we didn't have a PET MRI machine, unfortunately, so we've had to do PET CT first, then take the MR imaging. The limitation, though, in this particular work, if you were to use a PET MRI machine, we're led to believe by our radiology colleagues, is that we may not get the image, the image that we need in terms of the resolution, and so that may well be a limitation with a hybrid PET MRI machine in terms of isolating this precise anatomy.
Zita Belloc from Melbourne. We see these findings quite often on oncological PET, and your data suggests that it's specific, but what shall we do? Shall we press on and say in the conclusion that it's suggestive of, polymyalgia rheumatica, or shall we just
I think
describe it and leave it open?
Yeah, I think it's probably the take-home message at this point in time is that it's at multiple sites, rather than, and it's the whole picture, not just uptake at one or two sites. So look, I think if you saw a whole scan that was in keeping with multiple sites involved, I would suggest it, but otherwise I would probably just comment on the uptake and suggest perhaps some clinical correlation.
And I might just comment on that. A lot of the time when we're scanning patients for oncology follow-up, a lot of them are on immunotherapy, and some of them do have immunotherapy-related PMR.
Yes.
So sometimes if you see
Also
that,
relevant.
you can comment on it, and then they might, if they got referred to the rheumatology colleague, and they might deal with it appropriately.
Correct.
Some of them are asymptomatic.
Yes, yes.
Claire, I have a quick question, Claire. We use monoclonal antibodies for vasculitis, rituximab, tocilizumab. Do you have any data on follow-up of those patients before and after the introduction of monoclonal antibodies? And
No, I don't have.
Would be interesting to continue your research.
No, not at this stage. Sorry, Dixon. No.
Good. Yes, Alex. Yeah, please. Thanks, please.
In your cohort, have you had much overlap with pure bilateral rotator cuff disease? You would have had those admixed both clinically and on imaging, where you're able to differentiate.
As part of the wider study, all of these patients have had musculoskeletal ultrasound performed as well. So we do know whether their rotator cuffs are intact or not, and whether they've got issues in that particular regard. So we have probably, hopefully, accounted for that particular issue.
Thanks, Claire. I'd like to present this little plug to you. It's a token of respect and thank you. I'd like to introduce the third speaker. Now, it's actually a very interesting talk on the use of radiosonivectomy for arthritis from Professor Emerita Paramachia from St. Luke's Medical Center in the Philippines. I'd like you to welcome Professor Paramachia.
Thank you very much, Dickinson and Aurora, for the kind introduction. A pleasant good afternoon to each and every one of you. let me thank the organizing committee, especially Cheting Lee, for the personal call that she gave me to come over. And also, I'd like to thank the audience for staying on. I know it's a Sunday, it's the last lecture, so thank you, everyone. So the topic that I'm supposed to discuss today is an update, but there has been a scarcity of the literature, so some of my slides have been there for some time, but towards the end of my lecture, there will be some update. So by definition, radiosynovectomy is the radionuclide therapy of joint synovitis, inflammation, as has been discussed by the previous speaker, or synovial processes by intra-articular injection of radionuclides like yttrium-90 silicate and citrate, 186 rhenium sulfide, or 169 erbium citrate. As a backgrounder, in 1977, Alberg saw the need to stop the vicious cycle of target joints in hemophilic, which causes lifelong disability and interrupts the physical and social activities of the child by this procedure. Over the decades, it has gained acceptance by providing a simple, economic, and effective therapy for them. This is the self-perpetuating cycle of hemarthrosis, synovitis, and hemarthrosis. The cycle does not usually repair itself, hence the need to break this as early as possible. So this is the normal pointer. Sorry. So this is a normal joint, and this is the one that occurs in RA, and of course your rheumatoid, your hemophilic arthropathy. So again, this is what's happening in the joint. So much of macrophages setting in. And the mechanism of radiosynovectomy is the intra-articular administration of radioactive particles which are absorbed by the superficial cells of the synovium. The beta radiation leads to coagulation, necrosis, and sloughing of these cells. The main indications are the following, but it's best indicated for RA, rheumatoid arthritis, and of course the hemophilic arthritis. Osteoarthritis comes only 50% effectivity. So the radiosynovectomy is indicated in hemophilic arthropathy for grade 1 transitory synovitis, back to normal after acute episodes, preventive when there are more than 3 episodes of bleeding in 6 months. Grade 2, permanent synovitis. Grade 3 is chronic arthropathy. The indications for RA is in cases of rheumatoid arthritis after 6 months of disease-modifying anti-rheumatoid drugs, as was discussed previously, maximal therapeutic response after 3 months, some improvement up to 6 months possible, retreatment after 6 months, in florid synovitis after 3 months, you have saturation of the dose. Further indications are like joint prosthesis, especially knee and shoulder replacement with synovial effusion, palliative pain therapy in advanced stage of arthrosis. What are the absolute contraindications? Pregnancy, which is not quite a problem, especially in hemophilics because they are usually males. Breastfeeding, local skin irritation, and ruptured popliteal cyst in the knee. Also, a relative contraindication is if the benefit of the treatment is likely to outweigh the potential hazards. Extensive joint instability with bone destruction like ankylosis, we don't do the procedure anymore. And evidence of significant cartilage loss within the joint. Let me tell you about the scope of the problem in hemophilia. Approximately 1 in 10,000 births, hemophilia A, 1 in 50,000 births for hemophilia B. The annual incidence of about 400 babies in the US, around 400,000 worldwide, 28,000 in the US, and 25 patients of our potential patients as cited by the World Hemophilic Foundation. The impact of the disease is when you know that it is treatable. As a review for the younger colleagues, hemophilia is an X-linked recessive disorder affecting males, but usually the mothers are the carriers. It causes coagulation defects because of lack of clotting factor 8 for hemophilia A, 85%, and factor A for hemophilia B, 15%. Bleeding is usually at the musculoskeletal level joint. Some people would worry about the nosebleed, the gum bleed, but it is the joint bleed that is really worrisome. Hemarthrosis or joint bleeds are the most frequent bleeding episode arising from the subsynovial venous plexus where a lack of thromboplastic activity has been demonstrated. When intra-articular bleeding occurs, the blood breakdown products act as a potent stimulus for inflammatory response, and when this occurs repeatedly, it causes synovial hypertrophy. Antihemophilic factor, or AHF, is temporary, repeated, and quite expensive. How about chemical synovectomy using rifampicin, osmic acid? These are easily available, but painful and irritating and requires repeated intra-articular injections, usually weekly. And the patients are usually children, no? So it's not really good. The other treatment options are surgery, although both open and arthroscopic synovectomy may treat hemophilic arthropathy. They can result in joint stiffness and prolonged rehabilitation. Invasive, bloody, costly, and does not prevent progression of arthropathy, and although the success rate is over 80%. Here in surgery, you need 100% coagulopathy. In radiosynovectomy, we only need 30% coagulopathy. The best option seems to be radiosynovectomy. What are the advantages? It's a minor intervention, low cost, possible as outpatient procedure. It's possible in inoperable patients, no rehabilitation necessary. You can do simultaneous treatment of multiple or short intervals, provided you don't exceed the maximum level that is allowed. In cases with little benefit, retreatment or surgery is possible, that's after 6 months. And in hemophilia, lower factor replacement is necessary, as I have said, only 30% before doing the procedure. The disadvantages are it's not approved in tendovaginitis or bursitis because of the infection, the radiation exposure, it's ineffective in advanced instability or destruction of the joint. We don't do that, especially in ankylosis. So what seems to be the ideal isotope? It must be a pure beta emission, a shallow depth of penetration, focus on the synovium and not the surrounding tissues, the rate of energy deposition, the moderate half-life. The carrier should have sufficient particle size, about 10 microns, so as not to produce leakage, non-toxic, easy to use, and would degrade at the same rate of the isotope. So basically, this is an important slide because here you can see the choice of isotopes. We did not use P32 as there were previous reports of 2 leukemias occurring in children. We use yttrium-90. You must see that here it's important to see the particle size because it depends on the penetration and which joint to inject. So like for erbium, you can see here that the penetration is quite low so that you can use that in smaller joints. Another important slide is when you do the joints, the choice is yttrium-90 and the recommended volume is 5 ml. And as you go down the joints, the smaller joints like the ankle and the subtalar joints, you only use a small volume. So importantly, the total activity of the rhenium-186 at a single session should not exceed 10 MCI because we had patients who needed injection of the ankles and the elbows at the same time. You all know that hemophilia and rheumatoid arthritis are both systemic diseases. For yttrium-90, it must not exceed 400 megabecquerels or 11 MCI, and for erbium, not more than 750 megabecquerels. So the side effects are rare and quite temporary, like tissue necrosis is very rare, joint infection, radiation exposure is very minimal, and the best is there is no genotoxic effect in blood in humans, And as I will see in the show in the later literature, long-time study will not show any cancer or abnormalities. So there's no effect on the cartilage, and incidences of low leakage of less than 2%. What are the things that we must do after the therapy? Post-therapy imaging should be undertaken where possible. Patients should be followed out 6 to 8 weeks after injection and should include clinical and laboratory indices of treatment response, assessment of synovial inflammation, of course, radionecrosis. We can either do MR or ultrasound. Clinical examination is very important, and it can be repeated 3 to 4 to 6 months and 12 months. The importance of joint immobilization following treatment should be emphasized to avoid leakage, especially in the children who are very mobile. We had a 4-year-old patient, the youngest, who was really bleeding repeatedly, and so we have really to tell the parents that they should not really be mobile, but these young children cannot really be prevented from moving around. Reducing unnecessary radiation exposure to family members, although this is an outpatient procedure. Written instructions should be provided where required. And following treatment, patients should avoid pregnancy for at least 4 months. That's for the RA patients. Pain reduction typically occurs 1 to 3 weeks post-injection. Treatment failure is likely if no response is detected by 6 weeks post-injection. A few patients who have failed to respond to the first radionuclide injection report pain reduction and improvement of joint function following retreatment 6 months later. Just like I-131, we say it's a failure when there is no response after 6 months. 2 failed injections should not be followed by subsequent radiosynovectomy treatments. So our experience in the Philippines was that we had established cases of hemophilia from the National Hemophilic Center. They have to have a history of at least 3 bleeding episodes in the last 6 months, and with at least 60% coagulopathy at the time of the procedure. And of course, they are willing to follow up for a year. So I've said this, verbal and written information, immobilization, and so forth. And of course, we have to do the bone scan at the start, at the middle, and at the end of the study. So we did baseline radiography, 2-phase bone scintigraphy, and post-therapeutic whole body scan for leakage. So we could see if we could inject intraarticularly the isotope, and if we had difficulty, if it was too narrow, it was the rheumatologist who injected but sometimes the rheumatologists are afraid of the yttrium, so the part of the injection of the isotope, we do it ourselves. No? So this is a very good example. No? So this is a 17-year-old boy. We all know that this knee is the one that's the left knee, and this is the posterior view. And this is the blood pool study, which is the best phase of the scan wherein you can see which joint is really bad. So this is after 1 year. You can see that it's no longer swollen. This is 1 year after the study. And here in the skeletal phase, same boy, same 17-year-old. So you see here, and after 1 year, this is the appearance of the left knee. Of course, the ankylosis has also, and this boy, they're back to school. No? So this is at the beginning of the study and at the end of the study. And the procedure would say you drape the target joint and cleanse the affected knee, inject with xylocaine, slow infiltration, a gauge of 19 or 21 needle is placed intraarticularly, and aspiration of fluid and blood is done, taking as much as necessary and leaving enough fluid for the yttrium colloid to mix. We all know that the blood and the fluid are foreign bodies in the knee, so these are the ones that produce the pain. Bring the joint to a full range of motion to improve the distribution of the radiocolloid. So here we drape the site. As the needle is withdrawn, we flush it with NSS to prevent the extravasation and radionecrosis afterwards. A sterile plaster is placed and splint is applied. For the hemophiliacs, we place ice packs over the knees. So we give the detailed instructions. So this is the procedure. We get as much blood as possible for the hemophiliacs because these are the one that's irritating the joint. After the procedure, we want to make sure they're in the right place, so we image them and see the Bremsstrahlung lung. This is another hemophilic arthropathy. So we inject the xylocaine. We know we are in the right place because when we see the synovial fluid or the blood, that we are there. We withdraw as much blood as possible, and then we inject the yttrium 90 colloid. That's for the knees, the big joints. And we rinse it with NSS after the procedure to prevent radionecrosis. We put a plaster, we rotate the injected knee, we measure the activity. So that's the scan, that's the post images, post both knees. We put the bandage and the spice, and then we send them home. So other parameters for the success is the subjective complaints using the visual analog scale for pain scoring system, measurement of knee circumference, ability to ambulate and range of motion, better quality of life, lesser episodes of bleed, which was the most impressive result of the study, and there was improvement on x-rays and bone scans. So we had every 3 months follow-ups. And we considered it good if hemarthrosis decreased by at least 50 to 100%, moderate when the decrease was 25 to 49, and failure when the reduction was less than 25%, basing it on the early study of Van Kasteren. So at the end of the study, it was a red letter day for us, so everybody. And this was the result of the study, degree of improvement, almost 70 to 100% of the patients. So as for the parameters, the therapeutic result showed pain and swelling was 86%, the bleeding was 86%, the bone scan finding was 62%, and overall improvement was 90%. After 4 years, the radiosynovectomized knee was still free from bleeding excessively, some needing occasional factor VIII replacement, but not as frequent as previously. Other studies claim that as years progresses, the success of the procedure decreases and the bleeding may recur, but after 3 to 4 years follow-up, 80% of the patients who were followed up had still good knees with no major bleed. So you can see here that there is some failure after 5 years, so after some years. So how about the safety of radiosynovectomy? Properly performed radiosynovectomy should always outweigh any short or long-term side effects. 2 cases of leukemia using P32 in the US, so that it's no longer used in our local setting. No malignancy in yttrium 90, some chromosomal aberration, but not after 6 months, hence non-persistent. As I have said, limit is 400 megabecquerel per session. This is one of the studies in 2009. And with regard to the cancer incidence, it did not increase the risk of cancer at all. So the response rate was good after over 30 years. Side effects are related to penetration and leakage rate dependent on the radionuclide. For yttrium 90, it's still below unsafe levels for children. P32 and dysprosium 165 are not approved in Europe due to their half-life and lymphatic spread. So radiosynovectomy presents with a therapeutic effect of 60 to 94% for HA, hemophilic arthropathy. It's much dependent on how advanced the disease is and the length of time after the procedure. A good teamwork consisting of the rheumatologist, the nuclear medicine physician, and the pediatric hematologist is very important. So this is just a meta-analysis showing you that the favorable response over the years. So our study said 86% response, and this is just a meta-analysis for the response. Like for RA, it was also good, no? But the overall response rate was 73% plus minus 17. So, but the highest improvement was in hemophilic arthritis. So with the overall improvement of 80 to 90%, it must be the procedure of choice for hemophilics with repeated bleeding and in those where surgery cannot be done. It should be considered for hemophilics with joint disease, not responsive to replacement therapy, whom surgical synovectomy pose too many risks as in patients with inhibitors. those who are HIV positive, and those with post-surgical rehabilitative risk due to non-compliance. The key to the successful prevention of hemophilic arthropathy is an aggressive containment of the initial hemarthrosis before chronic synovitis develops. Regular clotting factor replacement, physiotherapy, and close follow-up are necessary. If chronic synovitis develops, radiosynovectomy should be done to prevent end-stage arthropathy. Okay, that's what to. Here. The most important element in this mode of treatment is that the effects are localized in the knees and there are no systemic effects. It is likewise preventive of joint deformities by preventing future bleeds or reducing bleeding episodes. And many studies, including our own experience, have demonstrated that it is safe. The most serious potential problem, skin burns caused by extravasation, but it can be prevented. The immediate flare and inflammation is treatable by NSAIDs, and no published malignant effects, again, for the past 30 years. So, coming to the conclusion, radiosynovectomy is minimally invasive, well-tolerated procedure that can be done on outpatient basis. It's cost-effective, requiring only 30% coagulopathy during the procedure, and it's effective in those refractory to medical therapy and those not suitable for surgery as the hemophilics. It prevents deformation and deterioration of the joint by destroying the pathological synovium, and it is an established and efficacious therapy for the treatment of bleeding joints in hemophilia. So this is just a study wherein we compared versus the corticosteroids. As the rheumatologist knows, usually the effects of the steroids are short-lived, 2 to 3 months, and this study showed much success. Like there were 99 rheumatoid patients. So the pain response was again evaluated, comparing it with the corticosteroid group. And so there was success in the patient with the radioisotope group or radiosynovectomy. So again, in the hemophilic patients, a multi-center study showed a significant response. And if you want a detailed of what I just said, it's been published in the therapeutic journal. One chapter was, we have one chapter in the Springer Journal of Therapeutic Medicine. So just for the update, we did some medium-sized joints. So now we were guided, because these are medium-sized joints, we are guided by the ultrasound, and we use rhenium. For the knees, we use the yttrium 90. Here we use rhenium. So elbow and ankles, we use rhenium 86 colloid. That's the bremsalon of the elbow and the both ankles. And actually, this is the update that I have found. So as I have said, there's a sparsity of literature. I found long-term results of 500 procedures in a 38-year period. That's the most recent. So again, they have proved that it reduces the hemarthrosis in hemophilics and RA in a 38-year period. And again, they showed really significant improvement. And the most important is no cancer was observed in this group of patients during this 38 period. So again, the effectivity of the procedure was demonstrated. So that was the conclusion. And this one, it was done in acromioclavicular joint using the 169 erbium. So again, the efficacy was proven. So I think those are, I have the safety. This is the last slide. Based on doses of 0.74 millisievert or 90 megabecquerel for the knees, they had a safety review, and it is recommended if the bleeding is recurrent and persistent despite aggressive factor replacement. So that's it.
Wonderful talk, Marita. It's good to see smiling patients, from time to time. I'd like to open the floor to questions. I'd like to ask a few questions, actually. I've done a few cyanobacteries, usually for rheumatoid arthritis and a few other types of arthritis. I have done yttrium for osteoarthritis. Do you give intra-articular steroids before you give the yttrium?
For the hemophilics, the protocol did not say we can give the steroids, but for the RA group, we really have to give steroids to prevent the flare.
Oh, that's understood. Yeah. The other question is that many of the joints that I've come across are quite deformed,
Yeah.
and I quite often used contrast or intra-articular radiological contrast to highlight the joint to make sure that we're in the synovium.
Yes.
Do you use that, or
Yes.
have you used that?
Yes,
Right.
we have to prove because there are some referrals that come to us that they are really ankylosed, so we usually don't advise the procedure anymore.
Thanks very much. I'd like to thank Professor Balankara, and I do have a little token of respect and gratitude to her.